Our first panel today is going to deal specifically with the issue of treatment as prevention for substance users in MSM, and I'd like to introduce two of my distinguished colleagues. First of all, Dr. Steve Shoptaw, a licensed psychologist and professor both in the departments of family medicine and psychiatry and behavioral sciences at UCLA. He's director of the UCLA Center for Health Promotion and Disease Prevention, which focuses on the integration of scientific and technological advancements from the best in academia with the strength of communities in an effort to conduct research, engage health service partners, and to produce innovative treatment options. Dr. Irene Kuo is associate research professor in the Department of Epidemiology and Biostatistics in the School of Public Health and Health Services at George Washington University. She has nearly 15 years of experience conducting research on infectious diseases, particularly HIV, HCV, and HBV, in substance using and other high-risk populations, particularly injection drug users. She's currently the co-principal investigator of a NIDA and NIAID-sponsored R01 using an information computerized tool to help link high-risk incarcerated populations into HIV care upon release. So I'd like to welcome both Dr. Shoptaw and Kuo to speak to us today.
Thanks, Kevin. Let's see if I can mess this up. Let's see. Thank you, Brad. Yes. Do you want to bring hers up too? I'll just run down on some of those. Okay. Yeah. I think it's right there. That's hers. Yeah. Thank you. Perfect. Thank you. Got it. Thanks. It's an honor to be here today. You know, the advantage of being in the field for so long is you get to meet a lot of friends, and I have to say, I walk among giants, and I'm glad you're here because it's good to see everyone, and I really appreciate it. I want to acknowledge my colleagues as well. First of all, CHIPTS, Dr. Rotherham, my good friend Kathy Reback, who's been a real colleague as we've developed some of these data sets we'll be talking about today. Rose Villegas, Rafi Landovitz, a new physician working with us. He's not a new physician, but he's a physician that's new to us. Wen Kao, Pamina Gorbak, Arlene Leibowitz, Tom Coates, and Roger Deedles. It's really a star-studded crew, and I'm really blessed to be able to work with them. I also want to thank the NIMH for the funding of CHIPS. My own funding comes largely from NIDA, and I'm grateful for them. One of the things you're going to hear about today is the world that, as I see it, from the perspective of substance users. Our funders as well, the County of Los Angeles, California HIV Research Program, and because I do work with medications, I also have grants from Medicine Nova and Pfizer. As you heard Dr. Fenton speaking this morning, it's a whole new ballgame right now. There's a lot of things in place today about HIV prevention that weren't there just a few years ago. First of all, we have a president who's given us a strategy, a guideline for addressing the issue of HIV and its prevention that is based on the principles of epidemiology and science. And some of the discomfort that's out there in the field is based on that plan, and there's a lot of conversations that are going on. But it actually is a good plan, and it's one that we're working hard to implement. The successes in combination prevention are really dizzying. Every day there seems to be more coming out about the ways in which the best of biomedical interventions can be integrated with behavioral interventions to bring about the reduction of HIV transmissions. We all know about these. There's IPREX, EBAN, the female microbicides, treatment as prevention, Mike Cohen's study 052, male circumcision, Maurer-Schechter's PEP studies. Who knows what happened with FemPrep? We'll know. But the bottom line is that 2011, in my mind, is to HIV prevention what 1996 is for HIV treatment. It really is a game changer. But I would be disingenuous if I didn't sit here today to tell you that nobody really cares about substance users. It's a condition that is governed largely by choice and morals, as you hear about regularly on CNN and all the sorts of ways in which We talk about substance use in this culture. And when you factor in men who have sex with men who also engage substance use, you heap even more stigma on the plate, and we could care even less about some of those folks. So I want to just sort of step up here first to say thank you to the conference organizers for recognizing that in this group of people who are at risk for HIV in this country, that somebody has the guts to say, let's really look at who's at risk, and let's start talking about some of these populations that face these risks through behaviors they engage, secondary to behaviors that we might find objectionable, things like substance use. So let's get them on the bus. So what are the compelling tools for HIV prevention and combination prevention approaches? We had a very beautiful presentation before, and I'm not going to go through it, but really focusing on among positives, testing and linkage to care. Using assertive combination antiretroviral therapies prevention for positive prevention and behavioral change. No medication is effective if you don't take the pill from the bottle and move it across the gums. Okay, it's got to go that way. There's got to be something that actually gets the pill out of the bottle and into the system. Major behavioral issues in there. Facilitation of comprehensive adherence here. In negatives, we're not going to spend a lot of time on anything other than what we have here in terms of needle exchange and substance use therapies, but I think these are really powerful approaches. And I want to recognize the HPTN and Stan Vermund, who I kind of borrowed this slide from. Also borrowed this slide, which is basically a recapturing of Dr. Fenton's presentation, and I don't want to spend much time on this, but really since the beginning of the reports about RV144, the vaccine trial from Thailand, it really has just been a game changer. Every day you go to work, you find out new stuff that's coming down the pike, and it makes you think in different ways about how we can go about bringing combination prevention into HIV treatment settings. So today's talk, I'm going to be giving you an overview to begin with. Dr. Kuo will be coming up and talking about some examples of ways in which we use treatment as prevention in substance users. So when I look at the beautiful data sets that are coming in, and kind of to parrot Dr. Field's great question, you know, one of the questions we have is where are substance users, and in particular substance using MSM in many of these data that we hear about when we hear about treatment as prevention working? And the answer is they're generally not there. If you run a clinical trial, a randomized clinical trial, to go out and prove treatment as prevention works, you're not going to pick our people to be in your study because our people tend to be largely non-adherent, unpredictable in their behavior, and all sorts of other things as well. So generally, the investigator would exclude those participants from the clinical trial for any number of reasons. So we don't know too much yet about whether treatment works as prevention in substance using MSM, and we hope to find some things soon. Dr. Kuo will be giving us some directions about ways in which that treatment topic can move forward. In HIV-negative substance users, especially substance using MSM, there may be many objections for taking ARTs, which are highly valued in the society, and as Dr. Fenton was showing, there's a waiting list of folks for ADAP, for people to get ARTs as treatment who are HIV infected already. So the question comes up, should we be allocating ARTs to people who are HIV negative who also engage otherwise objectionable behavior on a social level? I think that's a valid question and one that we have to deal with. One way in which we've dealt with this in the past is just basically say we're going to not pay attention to this, and I draw some attention to the post-exposure prophylaxis guidelines, where there was a long space of time that passed between recommendations of post-exposure prophylaxis for potential HIV exposure in the workplace compared to when it happened in your sexual life. There is a bit of a tradition here in how that there's a lag between what happens for the general population and then those folks who are substance users or MSM or otherwise objectionable. So, you know, I appreciate Dr. Fenton's comments, and I want to support that in terms of galvanizing us to move forward and be strong advocates for communities at risk here. Well, what do we know about what happens to substance users who have access to ARTs? Well, there's some very interesting data that show from the WISE, the Women Interagency HIV study, showing that crack cocaine use is significantly and negatively correlated with health outcomes for women compared to non-drug users, seeing increases in plasma viral loads, decreases in CD4 counts, and increases in morbidity mortality, basically indicating that people become more infectious and more fragile in their risk, in their health when they use cocaine. But in the MAX, we've done an analysis of HIV-infected MSM and saw that while we can measure significant negative impacts of methamphetamine use on infections, on immune parameters, particularly CD4, CD8 ratios, what we also see is that those negative and significant effects are swamped, completely washed away by the effect of ART. So while we can see that substance use in itself seems to have some interaction with the immune system, the effect of it, particularly in HIV-positive folks, the ARTs are just going to completely wash away, generally wash away whatever bad effects there are. One example that sort of disproves this, however, came from a colleague of mine, William King, who looked at some cross-sectional data in Los Angeles, a large sample of very poor, largely Latino and African-American men who have sex with men who were HIV infected, and his data showed that while the majority of these men, who were, by the way, living in Los Angeles on less than $500 a month on average, the majority had undetectable viral load levels. The one place where he saw the exception was methamphetamine users. He did not see that effect within methamphetamine users, and in fact, methamphetamine significantly degraded their immune function. So, I don't know, there's something specific about meth, and I'm going to talk about that a little bit later as we go along. And then finally, opioid substitution therapy for injecting drug users, injecting opiate users, can boost adherence to heart. So there's a very strong data set, and this is a paper out of Addiction, doing a meta-analysis showing the increased relevance of combination therapy for opiate injectors, that by somehow integrating HIV care within the context of addiction medicine can actually increase the outcomes for both. So basically, not a lot of data right now for substance-using MSM looking at treatment as prevention, but there are some data that talk about substance abuse treatment as HIV prevention. And one of the first places I feel like, since I'm going to be controversial, I might as well be controversial all morning, it would be to talk about the issue of something that really works, and it's been shown to work for a long time, and that's in injecting drug users, the idea of using syringe exchange or needle exchange programs. And I have the data table here from a long time old study showing that cities that adopted needle exchange programs saw decreases in seroprevalence in HIV compared to cities that didn't adopt syringe exchange programs. Why might that be? Well, syringe exchange isn't just about swapping needles. It's also about getting infectious disease information. It's about getting injection supplies, clean injection techniques. It averts infections, it increases QALYs, it's cheap, and moreover, it's actually more cost effective with higher incidence. So it's a good thing to think about. In terms of going forward and thinking about other interactions that can be done, or interventions that can be done with opiate injectors, we have the idea of opioid replacement. And in this, just because I don't know this crowd that well, I mean, many of you are from HIV prevention, I'm from drug treatment, we take these things for granted, ideas about opioid agonists, things like methadone. antagonists, things like naltrexone, or partial agonists, miracle drugs like buprenorphine. What we've seen is that in meta-analyses, we see that opioid replacement is HIV prevention in injected drug users, and the mechanisms that have been identified for how it works is it reduces craving for use of illicit opioids. It reduces frequency of injecting drug use, reduces the sex for money, exchanged sex. It increases cognitive functioning and the ability to understand prevention messages. You have less sharing of paraphernalia, you have regular contact with the treatment agency, and that increases the chances for medical and psychological interventions. These are very old data. Dave Metzger's early data showing that enrollment in methadone maintenance actually prevents HIV incidence. And here the blue bars are the folks who have who were not members of methadone treatment, and the yellow bars are the participants followed who were in methadone treatment, and you can see it's about a 2 to 3 to 1 reduction in terms of incidence. So what do we know about methadone, opioid replacement, HIV seroconversion? The early cohort studies showed conclusively that methadone reduces HIV incidence. Later studies showed that it was not only methadone, but it was the fact that people stayed in methadone. It's continuously coming to treatment that interrupted the incidence, the transmission. HPTN 058, which is a study to look at the efficacy of using buprenorphine in a country, China, where there is an outbreak of infections, is well on its way to finishing. And we'll be hearing results about that soon. Dave Metzger is running that one. But again, the minority of MSM are IDUs. The majority of MSM do not inject the substances they use. This chart here is something that I use as my Rosetta Stone. This is actually charting my work forward. I have in my group the fundamental philosophy that if we're going to do HIV prevention, we should work where the virus is, not where where the money says we should go. And this chart here I want to focus on. The large blue bar there is the HIV prevalence of men who have sex with men in New York City. And the red bars are the general population prevalences in sub-Saharan Africa. And what you can see here is that the prevalence of New York City MSM is it's comparable to sub-Saharan Africa, which if you work in communities of substance-using MSM, this is a no-brainer. But if you don't work in communities of MSM, it can be an epiphany to understand that the men who are having sex with men in our cities are seriously at risk, faces greater risk of HIV as some of the more endemic countries around the world. In Los Angeles, our HIV room temperature prevalence is around 19%. Ron Stahl has reported that looking at analysis of partial analysis of parceling out the contribution of substance use to HIV infection, and comes up with 2 studies showing between 28 to 33% of incident cases of HIV are found among men who have sex with men. One of the major and I think best drugs to study to understand this sort of association is methamphetamine. Across studies for multiple years, we see that methamphetamine use correlates with a 2 to 4-fold increase in risk for HIV transmission. And looking here, you can see in the cohort study, Michael Planky and the Max showed in probably the best data showing that 2 to 4-fold increase in new infections. Pamina Gorbach student, Lydia Drumright, published that same 2 to 4-fold risk increase in new infections, and then Susan Buckbinder and the folks at UCSF have been reporting in STI settings that methamphetamine mentions in the context of treatment for sexually transmitted diseases actually also increases the risk about 2 to 4 times. Well, here again is the compliments of LA Department of Public Health, again showing marching through the years, a relative risk of about 2.4, 2.2, somewhere in that range of methamphetamine mentions compared to non-meth users in new cases. So my good colleague, Dr. Reback, and I have hypothesized that in our work, we have seen that recreational users of methamphetamine who are MSM will average in the low 20% of HIV infection. Chronic methamphetamine users who are not seeking treatment, about 42% prevalent infection. At the outpatient clinic, by the time men walk through the door for treatment for methamphetamine dependence fully, 3 in 5 are HIV infected. And by the time they reach some of our residential treatment facilities, it's fully 86% who are HIV infected. This sort of association is not causal, but it does indicate that the more involved someone becomes with methamphetamine within the context of being a man who has sex with other men, the more likely he is to engage behaviors in situations where virus is, and more likely he is eventually to become prevalent infected. Using the thinking of Mike Cohen and thinking about the ways in which HIV transmission moves forward, we can see that methamphetamine actually, and other substances as well, but I'm using methamphetamine as an exemplar here. Methamphetamine changes the probabilities of infection in any particular event by changing the characteristics of the behavior. It may lead to longer episodes of unprotected anal sex, vaginal sex, oral behaviors. It changes characteristics of the individual. You might engage sex with someone who has other STIs. You may have bruised or bleeding mucosa. Viral loads could be high. You have high amounts of sexual concurrency, all things that are linked to efficient transmission, and then characteristics of the event, single versus multiple sources of the virus. Our group in Los Angeles, Rafi Landovitz, is leading an effort with the rest of us to bring post-exposure prophylaxis to methamphetamine using MSM. About 120 cases have been delivered to date. It's a small sample size, only one incident seroconversion, and in that seroconversion event happened in a non-adherent man. In general, it's been well tolerated, with time to PEP initiation. Adherence rates are comparable to non-meth using men who are on post-exposure prophylaxis. And this is in the context of high rates of risk behavior and high prevalent STI rates. Moving forward, thinking about substance abuse treatment as HIV prevention in MSM, following the footsteps of Ron Stahl, who initially reported the effects of entering drug abuse treatment as a way of reducing HIV infection. Dr. Reback and I conducted a randomized trial a few years back looking at contingency management, cognitive behavioral therapy, the combination of the two, and a gay-specific cognitive behavioral therapy in a group of men who were seeking outpatient treatment, 60% HIV prevalent. What we saw was that the treatments actually reduced meth use over time, and in particular, the blue bars here are 16 weeks, the red bars are 26 weeks, and the yellows are 52 weeks. You can see that the top performer was the conditions containing CM and CBT, with at the end of treatment, with all groups kind of catching up at the end. But basically, we got a twofer. We were able to reduce meth use, but we also saw that from baseline, but we also saw that we were able to reduce unprotected sex, that on average, men were engaging about 3 or 4 unprotected receptive anal intercourse events during the month prior, and then they would enter treatment, and then basically their risk behavior zeroed out, which we thought, well, you get 2 parts to this. We replicated this in a second study showing the same sort of drop in terms of methamphetamine from baseline to the end of treatments and to follow-ups, and again, sex risk zeroing out with treatment. So our thinking is that brains not on methamphetamine make better sexual decisions than brains on methamphetamine. So in our simple thinking, it's more cost efficient to help people keep drug off board than to deal with all of the sequelae downstream. And so we have really focused on, in Los Angeles, not only methamphetamine, but all sorts of other substance treatments as a way of lowering risk behavior, lowering the transmission dynamics within those who are most at risk in the HIV positive, and lowering the opportunities for engaging virus in the HIV negative, primarily by helping people make better decisions about their health, their sexual health in particular, by using interventions that are known to reduce drug use. So our initial efforts are underway. This sort of thinking is also being adopted by the HPTN, and in their thinking about combination prevention, there's a focus on substance using MSM, using antiretroviral therapies with broad risk groups, including African American men who have sex with men, and dominant culture substance using MSM. We've been looking for ways to better manipulate treatment levers to reduce substance use and associated risks in this group. One way is to use medications in opiate users and also in amphetamine users. Naltrexone seems to help people to reduce their meth use. Bupropion also helps people who are methamphetamine users to reduce their use, representing another lever. Mopoli Das and Grant Colfax up in San Francisco have demonstrated the ability and the feasibility of using these sorts of medication approaches with MSM to reduce not only meth use, but concomitant HIV risk behaviors. And then finally, of course, there's buprenorphine that's out there for the opiate users. Like I say, there's not so many opiate users who are MSM that are out there, but for those that are, buprenorphine offers a great opportunity. In behavioral therapies, like it or not, contingency management works. And trust me, I stand here to say a lot of people don't like that. But it does work. We've sort of rebranded contingency management into the language of behavioral economics and call it conditional cash transfers. And everybody likes conditional cash transfers, so that's our new line of work. We also are strongly attracted and use cognitive behavioral therapy and, of course, motivational enhancement. So I just wanted to end this slide by this is a very quick tour through my world, but focusing on the ideas of combination HIV prevention within the context of substance using MSM. We can see that all of these different elements that have been shown to be effective, and by the way, this is pilfered from Slim Abdul Karim, who presented this slide. I think it was actually yanked by Stan Vermund at the HPTN meeting, but it was with permission that I have it here. So showing that these various aspects of biomedical and behavioral interventions are there, they work. The challenge for us working with substance using MSM is to begin to find ways to take elements of this palette of interventions that have efficacy and integrate them with behaviors and other sorts of approaches to be able to work effectively in helping our substance using communities to avoid infection. And we're going to hear some examples of how this might work. Dr. Kuo.
Oops, hold on one second. All right. Well, first of all, I'd like to thank Steve for inviting me to be his second act in the Steve Shoptaw show. But I really appreciate the opportunity to talk about treatment as prevention among substance users. I think this is a really important topic, and I really also appreciated Dr. Fenton's introduction to treatment as prevention and focusing on, continuing to focus on the disparities that occur within HIV-infected individuals. And I know much of his presentation focused on men who have sex with men, and we see the incidence of HIV occurring among injection drug users going down, but still, a significant proportion of HIV-infected individuals in the country. There are still epidemics of injection of HIV being driven by injection drug use worldwide. So I think it's still, there's still an important group to focus on. So this talk is going to focus more on, I guess, more applied examples of treatment as prevention. And I know, Steve did a great job actually talking about MSM and substance use, which I actually will not be talking about, so that was great. And, but also focusing on treatment as prevention among HIV-negative individuals. So I know he covered that in terms of talking about harm reduction, needle exchange programs, and also drug abuse treatment. So my talk will focus more on HIV-positive, treatment as prevention among HIV-positive substance users. And so some of the main, I guess, activities that can occur around treatment as prevention among substance users is to, just to sort of recap, is to increase HIV testing and linkage to care, whether that's through, outreach or through drug treatment programs or through needle exchange, but identifying unknown HIV infections and then linking them immediately into care. And following up from that, it's really important to, we say linkage, but what does that really mean? Does that mean a referral to care, or is that really getting someone engaged in care? So the second focus for treatment as prevention among substance users should really hone in on engagement in care, and then also retention in HIV care, which we know is a big problem for substance users because of, for whatever reason, as Steve alluded to, chaotic lives and things like that. So, and then the third aspect of treatment as prevention for among substance users, I think, should focus on linkage and access to substance use treatment among drug users, so that they can remain engaged in the other parts of their care, in HIV care. So I'm sure a lot of you already know this, so I won't dwell on it too much, but I'll just briefly review. We all know that studies have shown effectiveness of HAART among drug users, and I'm talking specifically mostly about injection drug use studies. So evidence has come out of the cohorts from Baltimore, from British Columbia, from Europe, and we've seen that HAART can be effective among injection drug users. However, the backstory is that ARTs are effective among injection drug users or drug users who are adherent to HAART. But these studies have also demonstrated a later initiation to HAART than other non-drug using individuals and other non-injection drug using individuals. And those studies have also shown that adherence may not be optimal. And I think Steve alluded to the fact that you may be in drug treatment, but if you're still injecting at the same time while you're in drug treatment, the benefit of being on a HAART is actually reduced. So to that end, actually, a paper just came out that, thank you, Steve, for referring me to it. A paper just came out in Health Affairs, authored by Nora Volkov and Julio Montané, about stressing the need for models of integrated care for substance users. And what they were really pushing for was the integration of substance use treatment with HIV care, and there have been a couple of papers that have shown that integration of substance use treatment within HIV care actually improves adherence. But they also argue on the other side, the flip side, that it's important to also incorporate HIV testing and linkage into care in substance use programs. And I think, it seems like that would be a no-brainer, but I believe they even cited data that showed that, only 60% of substance use drug treatment programs even offered testing. So, and you think in this day and age, it would be a no-brainer to offer HIV testing in a drug treatment program. So these were the calls that they had made in this paper, and I'll touch on those, more on this throughout the presentation. So, so we still have the problem that injection drug use and even non-injection drug use, which I think deserves probably a lot more attention than injection drug use at this point, just because we've seen the rates decline in HIV incidence among injection drug users, but it's still a major problem. It's a driving factor in HIV transmission, somewhat not domestically, but definitely internationally. And for treatment as prevention, the question is, how do we get more substance users engaged and retained in and adherent to HIV care? As we saw, the previous evidence showed that injection drug users do benefit from HART, but their initiation into care is delayed. So I'm going to talk about a few examples. Some are directly targeted towards substance users and some are not, but they all, I'll give you a little background on sort of the picture of HIV in Washington, D.C., and you'll see why it's all sort of relevant in terms of substance use. So I'll just talk about treatment as prevention activities in Washington, D.C., and start out by talking about HIV in D.C. And I'm not sure how familiar people are with the epidemic that's going on in Washington, D.C., but these were a couple of headlines that came out in November of 2007 when the HIV/AIDS Administration at the Department of Health issued their first ever report on HIV cases. It was the first annual report, and it really, I mean, I think we benefit a lot from being in a city that has a national, international newspaper, but it really made the headlines because the report came out and said that there was an estimated prevalence of HIV of 3.1% of HIV in Washington, D.C., and it was the first time it had ever been reported. And so I borrowed this slide from Steve also, and basically I'm using it just to show you the rates that are found in Washington, D.C., and compared to some of the other cities where, which are known to have high HIV prevalence. As you can see, Washington, D.C. has an estimated prevalence of about 3.2%. And then when you parse it down by race and gender, among black men in Washington, D.C., we see an estimated prevalence of about 7.2%, and 7.1%. And, again, I'd like to compare this across the other cities, other major cities that were listed in this slide, and then also some of the other sub-Saharan African countries, which are thought to have a huge, high generalized epidemics of HIV. And this just goes to sort of support the fact that there's a generalized epidemic going on in Washington. I put this slide in just to show you the distribution of risk transmission for the cases that are found in DC. And as you can see, the majority of cases, not the majority, but more than a third of the cases are attributed to men who have sex with men. But then on the flip side, well, basically, what this slide is trying to say is basically DC has it all. And we have, MSM, a large MSM population. We have high risk from heterosexual exposure. And then we also have a large injection drug using population. So there's a lot of substance abuse in Washington, a lot of injection drug use. And then we also, I think incorporated in here, which, is not really listed in risk transmission, is non-injection drug use, some of which Steve alluded to. So these data are from the National HIV Behavioral Surveillance System that we do in Washington, supported by the CDC. And it just gives you sort of a flavor of the past year prevalence of substance use that we're seeing in each of these high-risk populations. I'll start with the heterosexuals at high risk. High-risk heterosexual is defined as living in an area or a neighborhood with high rates of AIDS cases and or poverty. And as you can see, 59% of the sample that we recruited reported binge drinking, at least at some point in time in the past year. 28% were ever injection drug users. 28% had reported using crack. And generally, if they reported using crack, they were pretty much using crack on a daily basis. For injection drug users, not surprisingly, almost 100% were injecting heroin, but what is interesting is that 61% also reported binge drinking and cocaine and crack use. And among MSM, we actually don't have the same epidemic that LA does in terms of methamphetamine, but we do, 30% of our sample reported binge drinking, 24% reported poppers, and 20% reported cocaine. So there's high prevalence of substance use in each of these high-risk populations here. And then you see the corresponding prevalence that we found in each of these populations. So I think these two are probably to be expected, but 5.7% in the heterosexual population was surprisingly, shockingly high. So I think because of this, DC has gotten a lot of attention in terms of a place to that desperately needs interventions, because we do have a large HIV-infected population. The new focus for us is treatment as prevention. So DC was was selected to be one of the cities that's involved in the HIV Prevention Trials Network Protocol 065, which is also known as TLC+. I'm not sure how many people are familiar with it, but I'll describe it a little bit. TLC+ is built on the sort of the test and treat model, which was developed by Ruben Granich and colleagues at the WHO. That was published a couple of years ago in the Lancet. And basically, the concept is if you test everyone in a community, get those people into care, and you suppress their viral load, the overall sort of bioavailability of virus that can be spread is reduced to the point where you can interrupt transmission events. So basically, if you reduce the viral load that's floating around in the community, you can reduce HIV transmission. So that's what TLC Plus is based on. And there are 4 different parts to it, but TLC Plus is actually very complicated. It's a very complicated study. There are 4 parts to it. The first part is let me see, maybe I'll just go to this slide. So this slide basically shows the study design of TLC+. And what it is the first part is to expand HIV testing, to use social mobilization techniques and routine testing, something which DC is already doing, has been doing since 2006. So expanding HIV testing, identify unknown HIV-positive individuals, and then linking them into care. And then part of the study actually is a randomized controlled trial where the individuals who are linked to care will either be randomized to receive a financial incentive to link into care or no financial incentive to link into care. So this, this study is actually testing a couple of different things. And then based on, after they're linked to care, basically their viral loads will be measured over time, and then they will also receive a financial incentive to be virally suppressed. And the overall goal is to basically, establish a reduced community viral load among the individuals who were linked to care and were part of the financial incentive experimental arm. And something to note, it's not on here, but I did actually check the protocol. But substance users and actually individuals with serious mental health disorders are actually excluded from the study. So it sort of supports what Steve had originally said, that substance users are often excluded from these randomized controlled trials. So it's difficult to know whether or not these experimental or these interventions can apply or can even be are effective in these populations. So that's just something to note. Even though I think I think because substance use is there's a high prevalence of substance use, I think it'll probably end up catching some people, but generally speaking, they're excluded from this study. So the next study that I'm going to tell you about, and actually it's unfortunate because I don't have any data. We just started this, but it's a study that was recently funded by NIDA and NIAID as part of the Seek, Test, Treat, and Retain RFA that was put out a couple of years ago, focusing specifically on the correctional population. I was pleased to hear Dr. Fenton mention this really high-risk population because they deserve a lot more attention than they're getting. So the study is called, our study, it's a study that's being funded and being operationalized in Washington, D.C. In conjunction with Brown University and New York University. So I'll just review a little bit about correctional populations and treatment as prevention. I'm not sure how how much exposure people have had here to correctional populations, but correctional facilities, well, approximately 14% of all HIV-infected individuals who are incarcerated annually, of all HIV-infected individuals, cycle through the correctional justice system. And so in this way, correctional facilities can offer a unique opportunity for intervention. They actually can provide a model of integrated care, just because, I hate to say, they are a captive audience, but you can also provide all the different pieces of HIV care that they need, all the supportive care that they need in one place. So in a way, it's like the most pure example of one-stop shopping. Now, in the past, some past studies have shown that incarceration was actually associated with treatment disruption and poor virological outcomes because of interruption of treatment, current treatment regimens, inability to get medications inside the institution. But actually, a lot of these studies came from British Columbia, and I think the issue of poor institutional healthcare services and inability to get medications is going to be very location dependent. I know in the DC Department of Corrections and the DC jail, actually, the quality of healthcare is quite good. And some anecdotal, reports that we've gotten from people doing some qualitative research, they've said that they actually, they go in sicker and come out healthier. So I think this is, just another little bit of evidence that that corrections actually can serve as a vehicle to provide quality health care actually to individuals who don't actually get it when they're outside. And so this is also seen in a couple of other papers that were put out where incarceration was associated with better virologic outcomes because of stability and availability of treatment. But now what we have seen is that once people are released, the continuity of care is suboptimal. So there are a couple of papers that really showed this. Some data from Texas indicated that prisoners who were released from Texas prison, only 5% filled their prescription within prior to having their 10-day supply of drugs end, and only at 60 days of release, only 30% had actually filled that prescription. So you can see there's a huge interruption in treatment for these individuals. Sandra Springer and colleagues also found that while people were incarcerated, they actually found that 60% of the HIV-positive individuals had virologic suppression while incarcerated, but this benefit was reversed after they were released, and they tested them at reincarceration and found that this had been completely reversed. And something that we also see is that there's a lot of competing basic needs for people when they're released. There's a need for housing. Housing comes up time and time again as a basic need. And I'm happy that Dr. Fenton had mentioned that homelessness was a major issue contributing to poor outcomes. But also the linkage to care and medication adherence ends up being lower in their priority because they need to meet these other basic needs. And so all these things can lead to lower virologic suppression post-release, suggesting the need for increased support for linkage to care for these individuals. We're conducting the study in DC. We haven't started yet. We're doing formative work now, and we're customizing our tool. But we're conducting a randomized controlled trial to look at the effectiveness of a computer-delivered sort of motivational interviewing, client-centered feedback delivering program that will hopefully increase adherence, engagement in care, and adherence to medications. And part of that is actually there's going to be a text messaging function to it where people will receive reminders to take their medications and make their appointments. And as I mentioned, we're still doing formative work right now. We're going to customize it, and we're going to launch the trial in the summer of next year. So I'd like to talk about just a little bit about this Partnership for AIDS Progress. It's a collaboration between NIAID, the DC Department of Health, and George Washington University. And we were asked to sort of do a needs assessment among HIV-positive individuals to look at substance use and mental health treatment needs and how that impacts their care in HIV, their HIV care. So it's a quantitative study. We focused on 4 main HIV clinics in DC. We recruited patients who were either newly engaged, marginally or intermittently engaged in care, and people who are long-term engaged in care who had substance use or mental health disorders in the past 5 years. We also talked with providers and asked what their experiences were in terms of dealing with individuals with these comorbidities and how that affected their engagement in care. So just quickly, I'm going to, I think these are all things that we, may know or probably know already about, what patients expressed as being facilitators and barriers to getting into care, patients who had these sort of disorders. Some of the facilitators included going to a center that had integrated care where they could get their services all in one place, provider structure, how they felt about ongoing substance use, engagement and relationship. And then some of the barriers, main barriers included, the one thing that really came out strikingly clear was the competing basic needs, housing and poverty. And so I'm going to present a couple of quotes for each of these things. I'll just focus on the integrated care and the competing basic needs. So from the patient's perspective, individuals who reported that they were able to get their care all in one setting actually said that it was easier for them to get the care that they needed. So I'll focus on this second quote. So the interviewer asked, when you came here, you stay for the majority? Yeah, I stay all day. Who do you see here? My therapist, my case manager, then I can go. It's a little program up here that I can go to. They do arts and crafts and they do all kind of stuff. Computers, they take you on trips. I go back and forth everywhere. I just wear myself out. When I do go home, I'll take my medicine and I'll go to sleep. So this person actually found it very useful to have everything in one place, but at the same time, it allowed him to be engaged in activities that didn't allow for him to go back on the street and experience any triggers that might get him back into drug use. And the first person, this person says, you get substance use, mental health, my HIV, dental, everything is right here in this building. That's why I'm saying it's not hard to get the services you need. You see what I'm saying? So when they're all together, it's not hard to get the services that you need. So we also patients also talked about housing and the difficulty of keeping appointments when they don't have stable housing, and then also not wanting to start medication because they don't have stable housing. So this person had said, about keeping your appointment, the interviewer asked, about keeping your appointments, did you used to not keep your appointments? The respondent said, yeah, I didn't used to keep them because at one point in time when I came up here, I was homeless and I was staying at the shelter. And the other person said, some of it is sort of like, I don't want to start meds until I have a stable place. You have that conversation, well, we're not going to be able to you may never have a stable place to live, so we have to come up with an alternative. So basically, the bottom line is that, because people have to worry about all these other things, they're not able to either initiate treatment or be maintained on treatment. And, this could explain why injection drug users are late to initiate treatment. I thought it would be interesting to actually provide some providers' perspectives. And these providers, they were, an incredible group of people, but they really focused on meeting consumers where they are, and they felt that drug users can still be engaged in care while using. This person says, a lot of my substance abuse patients, they come in here on a regular basis. They don't miss their appointments. They come. Now, are we giving them medicine? Maybe not, but they still come. And so the key there is that their patients, they've developed the sense of trust. Their patients come in, even though they're not on medication right now, still, they're engaged in care and still can be monitored. This person, this provider actually said that she felt that individuals who are, I think, heroin users actually can be very compliant because they're very regimented. They're probably more compliant because they're used to regimented medication. You have to take your heroin within a 24-hour span because you'll get sick if you don't. And you know about that time to do it. So if you're taking every day at 12 o'clock, my saying to them is, well, you take your medicine and then you must take mine. They go together. So after a while, they realize they were better off by not doing the illicit drugs little by little. So again, it's like working with the patient to provide customized care. And this provider also said that she wanted more training and screening, more assistance in how to screen individuals for substance use and mental health disorders, in order to better provide comprehensive care to their patients. So I'm running out of time, but I'm going to quickly talk about DC's programs to support treatment as prevention. So one of the things that they did was focus on treatment testing promotion, expanding the routine testing campaign, providing free kits and training to providers to implement routine testing in medical settings. Also, the innovative use of surveillance data to drive research and programming. For example, the community viral load that I mentioned before is going to be used as an outcome for TLC+, and it's also used for targeting hotspots throughout the city. They also did this recapture blitz where they were able to link clinic data with surveillance data, identify who was out of care, and then follow up with them. And then treatment promotion. Also, there's an innovative red carpet program where newly identified individuals would be guaranteed a next day appointment at participating clinics, and there are like 20 locations across the city. And all of these things combined, you can see this is a figure that shows the time to linkage to care. And so the blue bars indicate 3 months from the time of diagnosis to linkage into care. And as you can see, over time, it's going up. In fact, all of these, this is within 1 year. Within 1 year, it's all going up over time because of these multifaceted approaches to getting people into care. So maybe I'll just leave it this, but this is sort of what I came up with based on all the different things I presented. There are different approaches to increase engagement and retention and care to effectively implement treatment as prevention in substance users. Integrated care, assisting in meeting basic needs simultaneously, customized treatment plans, increased capacity for HIV care providers to deal with substance use disorders, and proactive linkage to care. So I think all these things combined can really work to support treatment as prevention and really help stop HIV transmission in DC. So that's basically it.